Okay, let's continue from slide 54 talking about the Bob Pod. Basically, the Bob Pod uses air displacement to estimate your body's volume, and by that, your body composition, fat versus lean mass. It also measures your body mass, your weight, using a very precise scale, and volume by sitting inside the Bob Pod. Body density can then be calculated, right? Density equals mass divided by volume. So it's taking both of them and calculating your density. Oh, just a second, the cable moved here. Here we go. Um, Once the overall density of the body is determined, the relative proportions of body fat and lean body mass are calculated by the machine. Um, the Bob Pod definitely differs from underwater weighing in that it uses air instead of water to measure body volume based on physical relationships between pressure and volume, which are tightly connected. Um, but the disadvantage of the system is that anything that creates volume and air disturbance is going to play a role in this case. So, for instance, clothing, for instance, hair, anything of that sort might create a mistake or an error in the machine's calculations. Um, let's see. Because it's very accurate, because it can sense very small changes, hair, anything that will change the volume or perceived volume will definitely play a role. In theory, you should shave completely the person in the Bob Pod and they should be naked. Obviously, that's not what we do. I'll say this again, that's not what we do, but that would give better results than anything else. Um, what else? So we see facial hair, clothing, watches, shoes, everything should be taking off, socks, and so on. Another problem is tracking changes over time with the Bob Pod, which is natural because the conditions are not always optimal between measurements. And then you see the Bob Pod itself. You can see on the right side the actual machine, and then on the left side the idea of how pressure and volume as is calculated. And then we can talk about underwater weighing or hydrostatic weighing, um, which also has its disadvantages. It's a classic measure, a very old measure that has been used in the past to measure body composition. Basically, you would want to have a specialized tank, but in theory, it can be, well, more than in theory, it can actually be done in a pool, but then it's less specific for that goal. The idea is to measure the density of the body and calculate percentage of body fat. What you need is a hydrostatic stainless steel weighing tank. You need a mounted chair, underwater mounted chair, and scale. You need a weighted belt and a nose clip because you want the person to submerge. Um, of course, there's simpler setups than that. That would be the ideal one. You need to know the dry weight of the person first. The person in minimal clothing. Once again, perfect would be without clothing. We're not going there again. Sits on the specialized seat expels all the air from their lungs and is lowered into the tank until all the person's body parts are in water or underneath water. The person has to completely not move, be motionless underwater while the water weight is recorded. Obviously, we're talking about the idea that the more volume that you submerge into the water, the more volume of water is elevated or expelled, depending on the setting that you have. You have to repeat this several times to get a dependable water or underwater weight measure. The body density can then be converted to percentage of fat using the Siri equation. Um, for more accuracy, you want RV to be physically measured before, if possible, um, although you can also estimate RV. Um, and then you can also estimate RV as 1/3 of FVC, of force vital capacity. Overall, when this procedure is done accurately and everything, all the equipment that you have is accurate and well scaled and so on and so forth, it's very accurate. Nowadays, the equipment is relatively easy to find, but this process is used less and less. Obviously, a full scaled apparatus costs a lot of money and takes a lot of space, and that's why a lot of places do not use that and just accept the error. Disadvantages: the most professional equipment requires to do under underwater weighing is expensive. Um, it takes a lot of space. Um, it takes a lot of time, relatively a lot of time. People have to go into the pool, then they want to shower, and so on and so forth. You have to have multiple measurements to get an accurate, dependable data. So it is losing its place in ways to be measured. Um, then you need to make sure that the water's temperature is exactly right um, and has to be elevated for a normal experience for the subject. Um, but the density of the water, which plays a role in this measurement, is affected by the temperature as well. So, and that is not factored into the equation. So, once again, every one of these processes has its problems, but um, you have to weigh the advantages versus the disadvantages. Now we're going to go to a completely different topic, which we've started to play, so to speak, with in Lab Week, and we will continue. And that is pulmonary function assessment at rest and during exercise. And a big part of this should be just refreshment of knowledge, but we'll go over it anyhow. Um, so we're going to talk about the more obvious and simple ways of assessing pulmonary function. We're not talking about PFTs. We're talking about the idea of using a gas exchange analysis system and different ways to assess that. We'll focus on pulmonary aspects and disregard pulmonary disorders. Um, so I guess that the simplest way to try and assess any problem is to see if respiratory rate, also known as frequency, the amount of times that you are breathing, the amount of breaths per minute is even normal. As simple as that. Okay? If it's not, you already know that you have a problem, or you might have a problem. One can simply listen to one's breathing for abnormal sounds, what we call lung sounds. And you're going to learn that as well. And all you need is basically a stethoscope and a person in general. You can also look at the person. You can look at the person. You want them not to be naked, but be decent. But men can take off their shirts. Women can too if they agree to, and if they're prepared for that. And just look at the mechanical aspects and the patterns of breathing, and see if there's any abnormalities, meaning slower breathing, faster, deformities in breathing. You can look at the area of your ribs. Is there any deformities in any area when someone is breathing? Asking their permission first, you can touch the areas and ask them to breathe and see and actually feel and see if there's a difference. You can also use the dyspnea and angina scales to indicate if something is wrong, assuming that they know how to use it. Of course, the dyspnea scale is related to shortness of breath, and the angina to chest pain or chest discomfort. Chest discomfort, not chest pain necessarily. And there's a difference between the two. So you want to make sure that the patient, the subject, the client understands the difference between the two. Then heart and lung sounds, as I indicated, can indicate problems in depth. You can, in some ways, through lung and heart sounds, understand if we have an obstruction, if we have inflammation, infection, fluids in the lungs, and perhaps asthma. What else? Any noises that you can hear using the stethoscope. So, for instance, rhonchi, if you have a low pitched sound, crackles, high pitched sounds, wheezing, which is high pitched whistling sound caused by the narrowing of the bronchial tubes. Does someone have stridor? It can be harsh, vibratory sounds caused by the narrowing of the trachea. What are the possible causes of abnormal breathing? But it's not limited necessarily to this list. It's just the main list: pneumonia, heart failure, COPD, asthma, bronchitis, and any foreign body in the lungs or the airways. And then we want to talk about any indication that means that you should rush the person or yourself, if you're self-diagnosing, straight to the ER. So if breathing difficulty, if the onset is sudden, if it's severe, if breathing stops, obviously, but that's an easy one, right? If you have cyanosis, the bluish color of your skin indicating that you have a decrease in oxygen supply. Any nasal flaring, meaning enlargement of the openings of the nostril when breathing. Okay, that might, if you have a mirror, that's relatively easy to look at yourself. And then abdominal breathing, using the abdominal muscles more, and you'll feel it. You'll mechanically and physically feel it. Of course, if you are using excessive muscle mass, or other respiratory muscles when you don't have to, and now you feel that you have to, that's an indication as well. And then obstruction of the upper airway by the symptom of stridor. Um, of course, besides initiating CPR if needed or ACLS, the continuance of the treatment will be in the physician's hand or the EMT once the person is in their hands. And if this is a client of yours, it's not a random meeting with someone, you definitely want to follow up on that and perhaps even adjust their exercise regimen as needed. Um, we can use plasma oxygen saturation, what we call O2 sat, through a pulse oximeter to indicate, saturation that is relatively low. Under 94, we start being concerned, but not panicking, not losing it. Under 88, we're at a bad place and thinking about oxygen supplement. Of course, if someone has uh, any kind of disorientation, abnormal speech, talking nonsense, that's a very bad situation. Of course, if it's not part of a joke or some kind of humoristic kind of thing. Immediate onset of fatigue, radical levels of lactate, which we definitely can check in the lab. Um, but these are not definite indicators of the problem yet. It's just a sign that something is abnormal. So it's not a diagnosis yet, but it definitely should alert you that something is wrong or might be wrong, to be accurate. Um, the more combinations of indicators that you have, the worse off the person is. Um, all of the apply of all of the above might apply during an exercise test. And then, in addition, if a person is breathing into a mask, as you've seen during lab week and had a bit of experience, and we're going to definitely accumulate more and more experience with that, you can be sure of that. Then we have more information that we can receive from the gas analysis system. Now we can actually see volumes. We can see patterns. We can calculate ratios. So, for instance, we now know, assuming that the machine has been calibrated and is showing accurate numbers and values, we now know minute ventilation, the amount of air that one inhales and exhales within a minute. We know tidal volume, the amount of air inhaled every time you take a breath. We know respiratory rate, meaning the number of breaths that you are taking per minute. And we know RER, which we talked about, which is the relationship, the mathematical relationship between the volume of CO2 and the volume of O2 used or entering through the mask or stimulating the sensor of the system, to be accurate. And then the system should allow you some kind of graphic output to assess pattern. So you can see the frequency, you can see if there's spikes, you can see if you're missing a breath, if it's shallow, if it's deep. You want to look at the pattern. And then we can compare normal breathing to abnormal breathing, which we'll have in the next slides. And then I see that I have a mistake in slide 77, and I apologize for that. It should be you do not need to memorize the patterns. So I hope you were on to that. So in slide 78, you see normal breathing relatively to time according to seconds. You see that the range is about 500 milliliters of air from inhalation to exhalation. Okay, and then you see that there's an automatic pause between breathing, and then it reoccurs, and you see that you have a nice shaped hill. Um, and we can talk about roughly 12 uh, um, breaths per minute times 500 milliliters is roughly 6 liters. Okay, and but it can also be, by the way, 7.5. I apologize. You remember I told you about the login, and I forgot to move the mouse. So here we go. So I'm back. Okay, then you can see in slide 79 different patterns. And I want you, I hope that when you saw this, you said, hey, it's kind of similar in a way, in principle, to ECG, meaning we have normal pattern and now we look at an abnormal pattern. It's not the same patterns as ECG, but we're looking at normal versus abnormal patterns. And if we just fixate in our mind, in this case, the upper pattern, anything that is different might be an indication of a problem. 1 second, I really need to your health. And then you see different kinds of breathing, okay? And we'll address them throughout the program in different ways. Um, so it's impossible to have abnormal breathing without secondary complications unless you really are trying to do something to yourself or you are very skilled at stimulating that. Simulating that. Normally, abnormal patterns means that there is a secondary problem and you need to look for the reason. These will include neural status and cardiac or hemodynamic responses. So any increase in cardiac volume or cardiac output and cardiac rate, hence called heart rate, can be expected. These two pumps, the lungs and the heart, affect each other. They have a mutual area where they affect each other and can actually affect the regulation of each other. So definitely going to see differences in both usually. Um, if a person is having a problem during an exercise test and they have a mask on them, touching the mask repeatedly is a sign. Pulling it off or tapping on it, we know that changes to the chest, with your shoulders or touching your chest all the time or pressing against it, trying to signal, are definitely signs that something is wrong. Um, Before anything, I think that once you're calibrating the machine, you want to look at the patterns of O2 and CO2. They should be normal. You learn that through calibration, and we'll show you that again and again and again because you've maybe calibrated the machine once. You're going to calibrate it multiple times. And then we want to look at RER. And at rest, we want it to be close to 0.7 in average. And I want to emphasize the word average because I don't want you thinking there's a problem if someone has 0.67. That's not necessarily a problem. Of course, when it gets lower, then we have a problem. Where if it's elevated and it should be around 0.7, we want to be alert. We don't want to freak out. We want to start asking the right questions and trying to see what is the origin of the mistake. I want you to remember that it can be from the person, it can be from the machine, it can be from both, okay, at the same time. Um, Nervousness. When someone is nervous, the nervous system works more, elevating CO2. If you elevate CO2, RER goes up. So that, once again, originates, in this case, the problem or the abnormal value is coming from the nervousness of the person. Someone that the mask has been put on for the first time, someone that hates being tested, you name it. Okay? Um, of course, we want to make sure that the increase of CO2 is not due to a different reason other than nervousness, and that it's not sending the system into acidosis, right? Meaning lowering pH too much. On the other hand, a decrease in RER might be an indication of alkalosis, meaning the increase of pH. So both of them are disturbing. Most likely, you'll see an increase in RER than a decrease. RER does not increase linearly from rest to maximal, so you shouldn't expect that. Because the ratio or the relationship between CO2 and O2 and how they change as gases is not linear. RER is used to estimate the extent of use of different substrates. At rest, we are mainly using fat through aerobic pathways to produce energy, and that's why the ratio is lesser than 1. The more we start moving, the more the nervous system and the red blood cells and the muscles are utilized, the more anaerobic glycolysis is used, and the more CO2 is produced, the higher RER gets. Then I want you to remember that total body capacity is made out of any pathway that allows you to produce ATP aerobically and any pathway that allows you to produce energy anaerobically. And while the tendency is to try and maximize aerobic capacity first, you always have anaerobic energy produced. And when your aerobic capacity is capped, if you want to increase your abilities, move faster, increase intensity, add motion, anything that adds energetic cost to what you're already doing will have to be paid for by anaerobic capacities or pathways. And that is why CO2 is going to shoot up the higher the intensity gets to maximal ability. And that's why RER goes up. So normally RER during an exercise test will go up from around 0.7 to above 1. Somewhere above 1. How much? Depends on the person, their sex, their health status, their exercise or fitness level, their level of nervousness, their psychological stamina, or ability to cope with situations, stressful situations, the protocol, the grade, the speed, everything that you're doing around them, the humidity, and so on should affect physiological responses, including O2 and CO2 production that immediately leads to changes in RER. Then we have the two specific other ratios or outcomes values that we want to address. One is 1.1. When RER is 1.1, it's one of the criterions that a person has maxed. Then you have a true max and a false max, or the difference between maxing and peaking. Peak, by definition, is the highest value or outcome seen lately, whereas a true max will show you on the graph that VO2 has plateaued, whereas workload is continuing to increase, and not everyone shows that plateau. The second number that we want to address, or value, ratio to be exact, is 0.8. There are two ways to look at this value. One is that it is a normal value on the range between 0.7 to whatever, maximal RER. The second one is that 0.8 indicates massive breakdown of proteins, but we know that that is not the major substrate for energy production. Uh, um, you know, within an exercise maximal test, we want people to max between 8 to 12 minutes. That's optimal. Even if the person is 20 minutes on the treadmill and has a max, which shouldn't happen, it's still not even close to what to any condition that should cause massive breakdown of muscle mass, or that 0.8 value. So if it stays constant, you should have by now. And if it stays constant, and the assumption is, or the truth is, that it is originating from muscle mass breakdown, rhabdomyolysis, or God forbid already kidney failure, then it should stay constant, and then you should look at the person and there should be more than enough indications that something is wrong. Another option is urine. If urine color turns to orange as opposed to yellow or white or transparent, and God forbid it turns to brown, you stop everything immediately and get this person as fast as possible, driving legally, not breaking the law, but as fast as possible to the hospital, to the ER. Okay? Because the clock is ticking and you don't have a lot of time. In general, I always teach that it is possible, if a very violent process or violent dynamic, let's call it, an extremely radical dynamic happens, complete failure of systems, the person can be dead within 4 hours. So you definitely want them at the hospital as fast as possible. And as I taught you during lab week, if someone comes to you and happens to tell you for any kind of reason that their urine was weird, the color was weird, it was orange brownish, the first thing you ask them, when did you notice this? You subtract that time, the time that has elapsed from those 4 hours that I told you, and you get to the hospital as fast as possible. Okay, then usually the person in this case will have an odd smell in their mouth, which is the breakdown of ketones and ammonia, the breakdown of ketones and production of ammonia. At that point, we do have the option, and should have the option in any lab, to check elevated levels of ketones. Let's see. We talked about what is in slide 85. Then we can tap into how does RER help us estimate what is broken down as the major substrate for that activity. Sorry. So let's look at slide 86. You can see that the oxidation of one molecule of a carbohydrate, of a carb, in this case glucose, the ratio between CO2 produced and the amount of O2 needed to produce it is 1 to 1. So when it is balanced, the ratio is 1 to 1. So the more carbs that you use in order to, or the more glucose you use in order to produce ATP, the more the ratio of RER will go towards 1. Okay? And then surpass that. And then you can see the ratio within the oxidation of a fatty acid molecule, where you need 23 units of oxygen for every 16 units of CO produced. So if you calculate 16 out of 23, guess what you get? 0.7. And that's how we know that fat is the major substrate broken down by means of aerobic pathways, or pathway to be accurate, at rest. And then there's a calculation for proteins. It's way more complicated because there are multiple amino acids and there's multiple proteins to break down. What else? Let's see. I'm going over slide 87. We talked about what's in 87, basically the 0.8 ratio. Then we talked about in lab week, so this should be a reminder of how minute ventilation, VE, changes graphically. How do we expect VT to change, and how do we expect respiratory rate to change? So if you remember, starting with VT, to make it easy, it goes up relatively linearly up to 60%. Then it is capped, meaning that the volume per breath is at 100%. Although intensity is just at 60, it's going to stay that way up to about 85% of intensity and then start decreasing. In relations to VE and RER, they are directly influenced by the production of CO2, which has which is influenced greatly by the production of lactic acid. So they seem the same as the change in lactic acid, and you can see these three graphs in slide 90. Okay, now we can talk about aerobic capacity, which is also called VO2, the volume of O2, and is used interchangeably. And we can talk about relative or absolute. Absolute is in liters per minute. It does not take under consideration any other unit that you might want to divide it by. For example, total body weight, or more accurately, active muscle mass. So the relative is mass related, and then the absolute capacity would be in liters per minute. The relative capacity is usually in milliliters per kilogram per minute. And once again, the kilogram is an indication of mass or weight in a place where gravity is greater than 0. And you either take in consideration total body weight, which is a bit inaccurate because then you're including non-active tissues that we know that do not consume oxygen during exercise, versus active muscle mass, if you know it, if you know that actual muscle mass, which is way more, much more accurate. Um, okay, so we talked about these slides. Now we can talk about the linear relationship, almost perfect relationship, mind you, between cardiac output and VO2. So cardiac output is the amount of blood that is circulated through the system during 60 seconds, a minute. Um, we know that the blood includes red blood cells that include in them hemoglobin that carries oxygen. So it makes sense to have a very tight relationship, although not completely perfect, but almost perfect, between how much blood you are circulating and how much oxygen you are offering. There goes um, the code again. Sorry. Um, and we know that there's also an effect to the saturation of hemoglobin or blood with oxygen. What else? We know that absolute VO2, when not taking into consideration uh, any kind of mass, is a weak to moderate indication of aerobic fitness, whereas relative VO2 is a very strong indicator. Now, the difference is, for instance, if you have someone with huge lungs or that is very big in size, their VO2, their absolute VO2 might be bigger or greater than someone else's. But then when you divide it by who's using that oxygen, it might be that every unit of mass is actually receiving less oxygen per unit, and then you're less fit. So just remember that. And that, of course, works perfectly always in mammals. Um, of course, the assumption is that the vast majority is utilized for skeletal muscles during exercise, and we know that 85% of up to 85% of blood circulation is to the skeletal muscles, whereas only 18 to 20% of the total amount of blood circulated at rest is to muscles. Um, what else? Just talked about the 85 and 18% indicated on slide 96. Um, basically, movement that requires or provokes the use of more muscle mass will elevate VO2 and VO2 max. Um, we can estimate active muscle mass quite accurately through creatinine, either in plasma or in urine. We have a few students, undergraduate and one graduate student, that are currently using this method to assess or estimate active muscle mass um, under different conditions. What else? So we see that women have an average lower capacity relatively to men. That is according to the laws of nature that apply to mammals. That the bigger the mammal, the bigger the capacity, right? And we see that the difference is after adjusting for capacity and mass, meaning relative units, might be between 8 to 12%. Then we can talk about the ability to improve aerobic capacity. Today, ultra aerobically trained people hit their best abilities or start hitting those higher notes, so to speak, higher volumes of aerobic capacity around age 32. That's due to the need for the system to grow and mature, and also allow enough or maximal adaptation to perfect training to occur. We also know that 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 with time, or the higher the, let's say it this way, the more you actually express the potential of your system, the harder it gets to improve at the same rate. Meaning that improving a percent in your maximal capacity when you are already at the highest values of humanity takes more time and more training than increasing your ability by 1% when you're non-trained. And that's what you see in slide 100. Basically, you see all the reasons that improvement or adaptation depends on physical potential, genetics, training potential, which is coach dependent, psychological potential, meaning your ability to cope, environmental conditions, obviously humidity, heat, what surface you're running on, and so on and so forth. Clothing, and that should be shoes. That's a typo, and nutrition. And then you can see the numbers that the average person, that I want to remind you, is about 70 kilograms or 154 pounds, which is non-trained person will have at maximal ability, which is about 45 milliliters per kilogram per minute, compared to the highest ever recorded, although I doubt the conditions it was recorded or achieved at, which is 93. The best ultra aerobically trained people today in the world will have about 84 or 85, and you see that as well. Anything beneath 45 milliliters per kilogram per minute can be regarded as what we call poor fitness, below average to be exact. Yeah, so that's it for week 6, and have a great day. Bye.